Hi, I'm Dr. Ken McClain. I'm the clinical director of the Histiocytosis Clinic at Texas Children's Hospital. Along with Carl Allen, our director of research, and Olive Eckstein, we're going to give you a short overview of the histiocytic diseases.
It's a group of diseases that basically look similar under the microscope, and in reality they represent a huge variety of diseases that are caused by a huge variety of things. Histiocyte is literally translated from Greek to mean tissue cell, and so it really just means it's a particular kind of cell that was sort of identified 100 years ago that more or less looks the same under the microscope. But what we know now is that these cells come from dozens, if not hundreds, of different origins, and they arise for a variety of different reasons. And one of the things we're trying to do at the Texas Children's Histiocytosis Program is really trying to dissect out the different types of diseases so we can figure out what's the best care for each patient's version of histiocytic disease. Langerhans Cell Histiocytosis is the most common histiocytic disorder, and this has really been a disease that's been confusing the pediatric oncology and immunology community for the last 100 years or more. And one of the reasons is the different variety of presentations or the ways patients can come about to have LCH are hugely variable from a baby who might just have a single skin lesion that'll go away by itself to really life-threatening disease that can look a lot like acute leukemia and require very severe treatment. There's a cell called a Langerhans cell that we all have in our skin, and the job of this cell is to be the guard against all the germs in our environment. It tells the immune system certain germs it's supposed to fight or certain germs that it's not supposed to fight against. And because this cell in our skin looks very similar to the cell in LCH lesions, the assumption has been that LCH comes from this skin cell that sort of goes berserk for some reason. And what we've learned through our research is that, in fact, the Langerhans cell in the skin has been incorrectly blamed for causing Langerhans cell histiocytosis. And in fact, LCH arises from a different part of the immune system that looks a lot like the Langerhans cell, and the type of LCH that a patient has really depends where in the development of that type of cell the cell kind of gets bad instructions and starts behaving inappropriately. HLH is a super confusing disease. It's Hemophagocytic Lymphohistiocytosis. The reason it's called that is because there's a specific phenomenon where when your immune system gets super activated, the macrophages, which are sort of the dump trucks of the immune system, they start to not behave themselves. They violate sort of personal space, and they start eating red blood cells and other cells in the bone marrow, and that's really what the pathologist is describing when they describe hemophagocytosis. What HLH really is, it's a syndrome that can be caused by many different factors, whether you're born with a problem with your immune system, or if you or I were to get Ebola virus, we probably would manifest the same symptoms as HLH. So basically it really just describes an immune system that's revved up. Because it's so activated, it's damaging the body of the patient. So because HLH can be caused by so many different things, it's an incredibly challenging disease for physicians to identify, and it's equally challenging to come up with a therapy appropriate for each patient. And I think this challenge is underscored by the fact that if untreated, HLH is almost universally fatal. So prior to the development of clinical trials or treatments for patients with HLH, fewer than 10% of patients were estimated to survive. So with the most current clinical trials organized by the Histiocyte Society, survival is around 50% or so. And so that's a huge leap from 10% to 50%, but clearly we have a long way to go to be able to appropriately treat patients with HLH.
There are several rare forms of histiocytic disorders. In particular, we are very interested in JXG, which is juvenile xanthogranuloma, and Rosai-Dorfman disease. These are even more rare than Langerhans cell histiocytosis. These are a non-Langerhans cell histiocytosis, so their cell of origin is different than LCH. And our understanding of the diseases is even more challenging than LCH because we have even fewer patients with these diseases. Juvenile xanthogranuloma can affect patients anywhere from their skin to inside their brain, and it can present such as a simple skin lesion that people kind of ignore for a while and eventually gets biopsied, or it can cause seizures if it's affecting, it's actually growing inside the brain. So it can be pretty minor or it can be really serious. Patients with Rosai-Dorfman typically present with large lymph nodes, kind of very suddenly get this big mass of lymph nodes, and once that gets biopsied, the diagnosis is made. It can also affect other parts of their body, especially the eyes. It tends to grow kind of right around the eyes and can cause a lot of problems there as well. Juvenile xanthogranuloma and Rosai-Dorfman disease are quite rare. We have tried to learn as much as we can about these disorders by seeing lots of patients referred into our clinic. And so we have the opportunity to monitor them and to understand their disease better than other places do because we get so many patients with these rare disorders.
Langerhans cell histiocytosis affects between 5 and 8 children per million population. For adults, we really don't have a good estimate. It might be 1 to 2 per million. Most of the children affected by LCH are between 2 and 8 years of age. The adults range from ages 30 to 50, but honestly, anybody from birth to in their 90s may be affected with Langerhans cell histiocytosis. For the hemophagocytic syndrome, the incidence is 1 to 2 per million. Most patients with a hemophagocytic syndrome are less than 5 years of age, but again, any child of any age range and adults are affected, and we're learning now that there are more adults than we once realized. Juvenile xanthogranuloma is also a disease primarily affecting infants and young children. JXG is about 1 per million, but we again see a few adults with this disease. And Rosai-Dorfman kind of spreads the gamut of ages with probably more adult patients per population than even in children. The adults are a particularly important group for us because, to me, they represent the real orphans in this disease. They are often challenged to find doctors who understand the disease, can diagnose it for them, and even more challenged to find someone who can treat it. So, to improve that situation, we have developed an adult histiocytosis clinic where every Tuesday afternoon I see patients from around the world with a variety of the diseases that I've mentioned already, LCH, JXG, Rosai-Dorfman, and HLH, but also a disease called Erdheim-Chester disease. It's something that's very rarely found in children, but more often in adults, and it's quite a challenging disease to diagnose and treat, and we're one of the centers who are very interested in this to find new treatments and help all adult patients.
We're often asked the question, is LCH a cancer? And even among experts, there's still some disagreement, but based on our understanding of LCH biology, we really do believe it belongs in the cancer family of diseases. And part of that depends on how you interpret what a cancer might be. Not all cancers are the same. So in the case of LCH, the disease is caused by a specific mutation in a growth pathway of a cell at a specific point in differentiation that causes that cell to stop behaving sort of the rules of normal growth and development. And that really, in my mind, is the definition of a cancer. This doesn't mean that someone that has LCH has the same diagnosis as someone with another type of cancer. I mean, LCH is its own disease, but I think it's really important to understand how it arises so we can come up with the best therapies. I think the other reason to consider LCH in the cancer family of diseases is that really allows us to ask the pediatric oncology community to help patients with LCH, just like they've helped so many other patients with Hodgkin's disease or acute myeloid leukemia. And in fact, LCH is just as common as Hodgkin's disease, and patients have just the same outcomes. And so I think there is some benefit to really categorizing LCH in this category so we can start to ask for research funding and be part of the cooperative cancer initiatives that have helped so many other children with cancer.
Treatment decisions are based upon what we call risk groups. So there's a group of patients that we call high risk because their liver, spleen, and bone marrow are involved, and they could have other areas also. But we know that patients with those 3 areas are going to need more treatment than those without it. So typically that's one group of patients for which we make the treatment decision. The second group are what we call low risk, which would be any part of the body, not part of the first 3, and that typically would be bone, skin, and pituitary. Finally, there are patients who have only a single area, such as, say, a rib lesion or just a skin rash, and treatment decisions about those patients depend upon the extent of the disease and how it is affecting the patient. In other words, is it painful? Is it very troublesome? The primary treatment for LCH is a chemotherapy drug called vinblastine and prednisone, and for the high-risk patients we add a pill called mercaptopurine. This has been the standard of care for many decades, and we are pioneering the use of a new treatment, a single chemotherapy drug, cytarabine, and as yet we're to embark on a clinical trial to decide whether that treatment is equal or better than the vinblastine and prednisone. If a patient does not respond to these two treatments, then we go to a second tier of treatments, which could include chemotherapy drugs called cladribine, also known as 2-CDA, or clofarabine, which we found to be a very effective drug. We rarely use radiotherapy for children because we don't want to cause unpleasant side effects. And the only time we would choose radiotherapy would be if there was a single spine lesion or perhaps of the upper part of the leg bone that was in risk of fracturing. There are some topical treatments that have been used over the years, but we don't find them terribly effective, so we usually use some sort of chemotherapy to treat skin disease, for instance. One of the questions that patients often ask us is what new drugs are available for treatment. Given new understanding in the biology of LCH, that understanding being that many patients have a mutation in a gene called BRAF or BRAF, there are drugs which target that mutation specifically, and we are using those drugs for selected patients when we find that the other chemotherapy drugs are not sufficient. We are also looking at the possibility of other new drugs based upon our understanding of the biology of the disease. So I think at this point in history we are at a very wonderful place that new drugs are coming along which are possible because of the new biological understanding, and that will be the focus of our work going forward to help discover the new biology and use the proper drugs to address those findings.
One thing that's critical to improving outcomes is really understanding the diseases. That's one of the reasons we created the histiocytosis program at Texas Children's Hospital. Is we started seeing so many patients when Dr. McClain developed this interest in histiocytic diseases. More and more patients started coming to the program. I think we're able to recognize patterns in these patients that can lead us to ask questions. It allows us to enroll patients on research trials. So almost all of our patients agree to participate in our biology studies, and so ultimately our goal is to test our observations in clinical trials and see if the ideas that are generated in our lab really result in improved therapies. So I think the bottom line is you have to understand patients, you have to test new ideas, and you just have to be paying attention, and that's what we can do here at Texas Children's Hospital. We're able to offer participation in our biology studies and in our research programs. Anyone in the world can participate with some of our initiatives. We're able to consent patients from all over the globe to our local programs. We're able to take your experience, put that into our database, and together, after we collect thousands of these cases, patterns emerge, and we can start to figure out what's the best way to treat patients with histiocytosis.
If we only have a small number of patients, we really can't make any good scientific conclusions from that. So by having a large number of patients participating all in the same kind of study, then we're able to kind of elucidate the etiology of the disease and how patients respond.
A fantastic collaboration that we've developed over the last 5 years is with the HistioCure Foundation. One of the projects we've started with them is called Spit for a Cure, and this is a fantastic project. We'll send you some kits where the patient, the mother, and the father can all really just donate a spit sample, mail that back to us, and from that information we've been able to get information about inherited risk factors for LCH and other histiocytic diseases from over 500 families. And this is really an experiment that has no boundaries, in that anyone in the world can participate.
Well, the resources include coming here or asking us questions, and we're always available by phone or email. The Histiocytosis Association of America has a very good website and information for families, and also the National Cancer Institute has a website with a chapter on Langerhans Cell Histiocytosis, which is very helpful.
If your child has just been diagnosed with a histiocytic disorder, we would welcome you to participate in our research or to seek our expert opinion in our clinic. We are trying to collect data on patients throughout the world with these diseases, and we do see quite a number of patients who come from all over the country and want to participate in our research so that we can make progress. We have already made a lot of progress in understanding histiocytic disorders because we've seen so many patients, and our goal is to continue to understand them, especially these rare histiocytic disorders such as JXG and Rose-Idorfin disease.